Bismillah ar-Rahman ar-Rahim. This is Dr. Muhammad Jawad from Nephrology Nursing Program at High Institute for Health Specialties. Welcome to our lecture, Access Complications. Complications of hemodialysis access create significant problems for kidney practitioners, the healthcare system, and especially for individuals living with the end-stage kidney disease. Chronic hemodialysis access complications include thrombosis, infection, ischemic steal syndrome, aneurysm, venous hypertension, hematoma, heart failure, and prolonged bleeding, and result in frequent interventions and increased morbidity and mortality. In addition, access interventions are often costly. There are many challenges may require for specialized surgical procedures. Thrombosis and infection are the most common vascular access dysfunctions, and thrombosis is the most common cause of vascular access loss. Thrombosis and infection occur frequently in arteriovenous graft and dialysis catheter than in arteriovenous fistula. The dialysis outcomes and practice patterns study reports that arteriovenous graft are 3.8 times more likely to require thrombectomy and 3 times more likely to require access intervention than arteriovenous fistula. Arteriovenous fistula thrombosis rates remain in the range of 0.2 to 0.8 per patient year, and arteriovenous graft thrombosis rates are typically in the range of 0.6 to 1.2 per patient year. The United States Renal Data System data confirm that arteriovenous fistula have the lowest complication rates of any available vascular access, 0.64 procedures per patient year, and 1.61 for arteriovenous fistula graft. Once primary fistula is established, thrombosis is the leading cause of failure in approximately 40% of cases. Infectious complications of vascular access are a major source of morbidity and mortality among hemodialysis patients. Previous studies have reported infection as a common cause of death, accounting for 9.5 to 36% of death in the hemodialysis patients. Vascular access infections most commonly found in patients utilizing dialysis catheters are reported to be source in up to 48 to 73% of all bacteremias in hemodialysis patients. The risk of bacteremia with the tunneled cuffed catheters averaged 2.3 per thousand catheters days. That translate into approximate 20 to 25% bacteremia risk over the average duration of use. The risk of infection averaged 10% in graft, 5% in transposed fistulas, and less than 2% in non-transposed fistulas. Ischemic steal syndrome secondary to hemodialysis arteriovenous access occurs in approximately 5 to 10% of cases. The pathophysiological basis for this condition is a marked decrease or reversal of flow in the arterial segment distal of the arteriovenous fistula or graft, induced by the low resistance of the fistula outflow. Mild cases can be observed closely, as most of them will reverse in a few weeks. However, severe cases require immediate intervention to prevent severe ischemic complications, including ischemic neuropathy and ischemic gangrene, with a potential need for amputation. Several surgical and endovascular treatments have been used, including access ligations, banding, distal arterial ligations, and distal revascularizations, interval ligation. The best reported result for treatment of dialysis excess associated steal syndrome with a maintenance of excess functions and reversal of symptoms have been obtained with the distal revascularization's interval ligation and the endoluminal assisted revision. Aneurysms and pseudoaneurysms resulting from improper needle site rotations or as a complications of more proximal stenosis are less frequent complications of vascular excess. Arteriovenous graft pseudoaneurysm can develop profuse bleeding and require emergency surgical intervention. Appropriate selection of dialysis staff for excess cannulations, together with the cannulation training and educations for staff members and patients, may reduce the risk of this complication. Venous hypertension occurs in approximately 3% of fistulas and the graft and is usually related to the central venous stenosis. Percutaneous transluminal angioplasty of the central venous system supplemented by the stent placement as needed is effective and considered the primary treatment for such lesions due to the lack of viable and safe surgical options. Hematoma result from the needle infiltrations. Needle infiltrations of a new fistula is a relatively frequent complication which occurs most commonly in older patients. If the access has been assessed as a mature for vein puncture, poor cannulation skills are often the root cause of infiltrations. Sample policies and procedures for cannulations of a new AV fistula are available at this website. Heart failure. High output heart failure from fistula placement occurs if fistula flow exceeds 20% of cardiac output. This complication is extremely rare, less than 1% of cases series. Prolonged bleeding should not be overlooked and should raise suspicion of high intra-access pressure, outflow stenosis, or local inflammation. Prolonged bleeding may also be caused by excessive hyperonization of the blood circuit, excess lacerations during previous cannulation, or skin atrophy. Clinical examination of the site should be performed and the previous statistic or dynamic venous pressure measurement should be reviewed. In conclusion, vascular access management has improved dramatically over the past decade, promising new therapies including catheter lock solutions and biological tissue engineering. It is hoped that these and other new technologies may decrease the future incidence of vascular access complications. Thank you for your attention, and I hope we will meet in next online lesson. Thank you for attention again, and I am looking for your questions and feedback.